by the APMA's Coding Committee. Hi, I'm Larry Santi, APMA trustee. I'm an ICD-10 committee presenter for this webinar. This webinar is the fourth in a series called ICD-10 is Here, produced by the APMA's Coding Committee. And this is the first of two parts. Tonight we'll be doing the diseases of the musculoskeletal system and connective tissue. And since this is a very, very important chapter for us, since it has many of the diagnostic codes that we'll be utilizing, we've actually divided it into two parts for the first beginning part. The part one tonight will be going over the general instructions and rules. And part two will be going over many numerous examples to show how we utilize these rules and come up with a proper diagnostic code. We have started with a very general introduction to ICD-10, and now we're going to dig just a little bit deeper into the conditions specific to ICD-10 coding. We'll have time for your questions that are pertinent tonight's webinar at the end of the webinar. Please type your questions in the question box located on the webinar toolbar. Today's webinar is only for members and is being recorded, and you can watch it again by visiting apma.org/ICD-10 or apma.org/webinars. And as of today, the webinars of that particular evening will be on the website that day. So you can go ahead and access them from our website and review them prior to the webinar. If you have any questions on webinars, please contact APMA, specifically the Health Policy and Practice Department at coding.hpp@apma.org or calling 301-581-9200. Make www.apma.org/ICD-10 a favorite on your computer for webinars, for updates, and for other resources. This is the fourth of approximately 19 webinars scheduled for the first and third Thursdays of each month up until the due date of October 1st, 2014. I should say D-Day. Please note, members will need to register for each webinar. To register, go to www.apma.org/ICD-10 and look for the webinar series. APMA is providing a great option for members as ICD-10 is Here seminar series. Sign up today for the first seminar in Atlanta on March 1st, Midwest, April 2nd, at the Annual Scientific Meeting in Honolulu, July 27th, and in Philadelphia, August 16th. There'll be one or more, so please check your APMA website. Before I start tonight's webinar, I'd like to discuss also our APMA Coding Resource Center. For those of you who are not familiar with it, if you look at the screen, you'll see that it has everything you need to know for coding and proper documentation. For example, you can get your CPT codes, your ICD-9 codes, your ICD-10 crossovers, as well as HCPCS codes, Medicare LCDs, and CCI edits. It's a great resource and one of the most important resources you can have to utilize in all your coding needs. Now, as we discussed previously, at the beginning of each chapter, you will find guidelines and instructions for that particular chapter. Prior to utilizing that chapter, it's always advisable to read the guidelines and instructions because that will give you the groundwork on how to use the codes of that particular section. So what we'll be doing tonight is going over these guidelines, particularly for Chapter 13, a musculoskeletal and connective tissue chapter. And since the chapter is very large, this week and next week, I'll be going over codes from approximately M00 to M50. The first thing we see in our guidelines is site and laterality. Most of the codes in Chapter 13, you must indicate the site and laterality designations. This represents bone, joint, or muscle involved. Now, where there is more than one bone, joint, or muscle, you're usually able to find multiple site codes that will be available. Now, for categories where there are no multiple site codes available, you must provide more than one bone, joint, or muscle code in order to get that particular diagnosis. For certain conditions, the bone may be affected at the upper or lower end. For example, avascular necrosis of bone or osteoporosis, M80. Though the portion of bone affected may be at the joint, the site designation will be the bone, not the joint. Many musculoskeletal conditions are the result of previous injury or trauma to a site or recurrent conditions. Bone, joint, and muscle conditions as a result of a healed injury are found in this chapter, Chapter 13. Recurrent bone, joint, or muscle conditions are also found in Chapter 13. Any current acute injury should be coded to the appropriate injury code from Chapter 19. Chronic or recurrent conditions should usually be coded with a code from Chapter 13. Now, if it's difficult to determine from the documentation in the record which code is best to describe a condition, you must query the provider. This is why documentation is very important. The more we document, the easier it will be for the coder or the coders to assign the appropriate ICD-10 code. Without the proper documentations, the codes cannot be developed properly and therefore might end up with a invalid code or lack of payment. Seventh character A, for coding for pathological fractures. Seventh character A is used for as long as the patient is receiving active treatment for the fracture. Seventh character D is used for encounters after the patient has completed active treatment. The other 7 characters listed on each subcategory in the tabular index are to be used for subsequent encounters for treatment of problems associated with healing. And these problems could be such as things as malunions, non-unions, and sequelae. Care for complications of surgical treatment for fracture repairs during the healing or recovery phase should be coded with the appropriate complication code. So again, we might be seeing that we're going to use combination codes from different chapters in order to get the proper diagnostic codes together. Osteoporosis. Now this is unique because osteoporosis is a systemic condition, meaning that all the bones in the musculoskeletal system are affected. Site is not a component of the codes under the category M81, osteoporosis, without current pathological fracture. The site codes under category M80, osteoporosis, with current pathological fracture, you must identify the site of fracture, not the osteoporosis. Use an external cause code following the code for musculoskeletal condition, if applicable, to identify the cause of that particular musculoskeletal condition. Now, as was explained earlier by our seminars, exclusion 2 means that 2 particular conditions that can occur together can be coded together. So, for example, in Chapter 13, our M chapter, arthropathic psoriasis can be utilized with the other codes in Chapter 13. The other conditions as follows. Certain conditions originated in the perinatal period. Those are the P04s to P96. Certain infectious or parasitic diseases, A00 to B99. Compartment syndrome, very important for us. T79.8 dash means that's to continue. Complications of pregnancy, childbirth. Congenital maldeformities, deformations, and chromosomal abnormalities. That's a Q00 to Q99. Endocrine, nutritional, and metabolic diseases. That's our E codes, E00 to E88. And again, an important chapter for us, especially when it comes to diabetics. Injury, poisoning, and certain other consequences of external causes, S00 to T88. Again, a very important chapter for us. We'll have many of our injury codes, such as fractures. Neoplasms, C00 to D49. Symptoms, signs, and abnormal clinical and laboratory findings, R00 to R94. Now, in this particular chapter, the chapter is divided into what they call blocks or subchapters. Again, this is a very, very large chapter, so let's go through the various blocks. M00 and M02 is infectious arthropathies. M05, M14, inflammatory pathoarthropathies. M15, M19, osteoarthritis. M20 and M25, other joint disorders. That'll be a very important subchapter for us. M26 to M27, dental facial abnormalities. M30 to M36, systemic connective tissue disorders. M40 and M43, deforming dorsopathies. M45 to M49, spondylopathies. M50 and M54, other dorsopathies. M60 to M63, disorders of muscles. M65 to M67, disorders of synovium and tendon. M70 to M79, soft tissue disorders. M80 to M85, disorders of bone density and structure. M86 to M90, other osteopathies. M91 to M94, chondropathies. M95, disorders of the musculoskeletal system and connective tissue. M96, intraoperative and post-procedural complications, disorders of the musculoskeletal system. M99, biomechanical lesions that are elsewhere classified. So as you can see, this is a very large chapter with a lot of subcategories. And again, a very important chapter for orthopedics and podiatry. Continue on with M19, other and unspecified osteoarthritis. Excludes one. Now, when you see excludes one, this particularly tells us that these particular codes cannot be used together with the codes in this chapter, since the two conditions cannot exist. So excludes one, polyarthritis, that's the M15, which means that this particular code cannot be utilized with other codes in this particular chapter. M19, other and unspecified osteoarthritis, we have exclusion 2. This indicates that the two conditions may be used together or may be seen together and can be, therefore, coded together in that particular encounter. So on the exclusions 2, we have arthrosis of spine, M47, hallux rigidus, M20.2, and the osteoarthritis of spine, M47. M20, acquired deformities of fingers and toes. Again, another subsection is very important to us. Excludes 1, acquired absence of toes. Well, obviously, you can have deformities of toes if we have no toes or fingers to be seen. Congenital absence of fingers and toes, and congenital deformities and malformation of fingers and toes. So these particular diagnostic codes cannot be utilized with those particular codes in this particular chapter, since these codes cannot exist together. Okay, continuing on with M79.6, pain in limb, hand, foot, fingers, toes. Excludes 2, pain in joint. That means these two diagnostic codes can be used together because you can have a pain in a limb as well as pain in a specific joint. Now, there was some confusion from a lot of our members who have been emailing us about why are there only 5 digits or 6 digits, 6 characters, I should say, in the ICD-10 code when they thought that all ICD-10 codes should have 7 characters. So we'll just go over the anatomy between ICD-9 versus ICD-10. Now, as we know, in ICD-9, we can have up to 5 digits. Usually starts off by 3 characters with a decimal point, and then 1 or 2 characters following the decimal point. Usually, the first three characters designate the category, and the last 2 characters designate the etiology, anatomical site, and manifestation. That's our ICD-9. Our ICD-10 codes can go up to 7 digits. It doesn't have to be 7 digits. It can be 5. It can be 6. Not all of our ICD-10 codes will be 7 digits. But in comparing it to the ICD-9 codes, again, we have the first 3 characters The first character is always a letter designating the chapter. For example, tonight's chapter, Musculoskeletal Connective Tissue, is the M chapter, or chapter 13. So if you look at ICD-10 codes, the first three characters, just like the ICD-9s, with a decimal point, and that's considered, or that designates the category. Then we have three other characters following that, or up to three characters following that, which designate the etiology, anatomical site, and severity. And last but not least, we have the seventh character, which is the extension character. And again, not all chapters require the extension, depending on the chapter. An important chapter for us that we'll see that particular seventh digit will be our injury chapter, chapter 19, or the S codes. Well, let's start taking this apart and start with an example. An example we'll use is pain. Okay, so we first start with the third character, and we see that pain, for example, in the ICD-10 system, will be M79. Now, when you look at the code, you see M79 point dash. The dash tells us that we have to continue developing this code to more specificity. So we know if we stop at M79 points, it'll be considered an incomplete code and obviously invalid. So next we go to a tabular index, and we have now to define the site etiology manifestation. So getting back to our example of pain, M79 point dash, we now go to the fourth character. And we see that as we scroll down on our tabular index, M79.6 is pain in limb, hand, foot, fingers, toes. But notice the dash. That tells us we must continue developing this code. So we continue to our fifth digit. And again, this increases the level of specificity. And again, this fifth digit may be a letter or a number. So let's get back to our example of pain. M79.6 pain in limb, hand, finger, toes. Now we have M79.60, which is pain in limb. We're getting more specific. But again, notice, the dash is still there, which means we have to continue developing this code. Now we get to the sixth digit, and the sixth digit is even more specific, and usually describes specific location or cause. Now we know, as we said in the beginning of our instructions, that this chapter must show laterality. So our sixth digit may be 1, which is for the right, 2 is for left, and 3 is our dreaded unspecified. And again, we want to try to stay away from that unspecified. So we either want either a right or a left, especially in podiatry. So getting back now to our example of pain, we have M79.60, that's what we left off with, pain in limb, unspecified. And we see M79.671, pain in the right foot. Now if you look at the code, there's no more dashes, which means the code is now complete. So if we look at this particular code, pain in right foot, it only has 7 characters. I'm sorry, it only has 6 characters. The 7th character is not necessary. But let's assume we needed a 7th character. And let's assume that we only have 5 characters. How do we get to that 7th character? And that's where you utilize the dummy character X, or the placeholder. And this allows for further expansion. So we can use this placeholder in the 4th, 5th, or 6th character. If a code requires a 7th character, the 7th character must be placed only in that particular place, the 7th character. Using that 7th character in the 4th or 5th would make that code invalid. Therefore, the use of the placeholder. The 7 characters are usually considered character extensions. They are typically letters, and they they describe conditions or timing of the visits. It's used to give more information about the events related to the reason of the visit or service. And again, please note, not all chapters or codes require that 7th character. We'll see it mainly when we get to our injury chapter, which is chapter 19, or the S codes. But let's look more at that seventh character. So if we're utilizing non-fracture care in our treatment of the patient, the seventh character can be A, for initial encounter, D, for subsequent encounter, or S, as just sequela. Now let's assume in treatment of the patient in that particular visit or encounter, we do have fracture care. Then the seventh encounter would be a little bit different. We would have A, for initial encounter, for a closed fracture, B, initial encounter for an open fracture, D, subsequent encounter for a non-healing fracture, G, subsequent encounter for a delayed healing fracture, K, subsequent encounter for fracture with non-union, P, subsequent encounter for fracture with malunion, or S, for sequela fractures. Now another question might pop up is, do we have to memorize these? The answer is no. At the beginning of each subsection, this will be listed out. So very simply, before you finish developing your particular ICD-10 code, always read the instructions at the beginning of the chapters and the subchapters. Again, in that particular legend, all this will be spelled out. So now let's go to an example. Let's take what we've gone over so far in our instructions and guidelines, and let's try to put it together in a presentation. So what I presented is painful hammer toes on the left foot. And what we're going to do in this particular presentation is show, 1, painful hammer toes on the left foot, 2, pes planus on the right and left foot, and 3, pain in limb. So in doing so, let's take a typical patient, Mr. Smith, a 50-year-old male, presents for an initial visit with painful second, third, fourth, and hammer toes on the left foot. Let's go to his history of present illness. So Mrs. Smith states that the hammer toes on the left foot have been hurting him for about 1 year. He has discovered that when he ambulates with shoes or sneakers, taking his shoes off helps him make it feel better. He does not remember any trauma and is not work-related. Now again, for purposes of simplicity and moving forward, I'm not giving it a whole exam and management type of note. But again, if this was a true note, we have to go over the complete history, family history, social history, and a complete review of systems. But for simplicity and for saving time, let's jump over to our focused physical exam. Now again, if this was a true examination, we would have a vascular status evaluated, neurological status evaluated, dermatological. Now let's skip over right to our musculoskeletal. So on the musculoskeletal, we see the left foot. Foot type would be pes planus. Normal range of motion for subtalar, metatarsal, and ankle joints. We look at this particular patient, we see the forefoot reveals severe, rigid contractures of the second, third, and fourth toes with no range of motion at the PIP joints. The patient has hyperkeratotic tissues, lesions are noted on the dorsal aspect of the second, third, and fourth toes over the PIP joints with tenderness and palpation. No signs of infection and muscle power tone is within normal limits. Now we turn to the right foot. And again we see that the foot type is pes planus. We have a normal range of motion in the subtalar, metatarsal, and ankle joints. There are slight flexion contractions of the second, third, and fourth toes with good painless range of motion. There is no hyperkeratotic lesions noted, no signs of infection, and muscle power and tone within normal limits. Radiologically, review the patient's radiographs of the left foot and reveals contracted second, third, and fourth toes with no joint space noted at the PIP joints. All other joints appear normal. There's no evidence of any fractures or dislocations. On the lateral view, foot appears flat with a decrease in calcaneal inclination angle. So now what we're going to do is take all this information and come up with an assessment. Okay? We see 1, painful hammer toes on the left foot. We have pes planus both on the right and left feet. and we have pain in the left toes. Now, to finish off our exam and management, we have here a plan. And we have, for example, Celebrex 200 milligrams. We discussed with patient better shoe gear with custom-made orthotics. Surgical options were discussed. And the patient is to return for 1 week follow-up. So let's put this all together and come up with some diagnoses. Well, if this is prior to October 1st, 2014, we would have hammer toes, 735.4. Notice there's no need to put any type of laterality. Pes planus, 734.0. And pain in joints of toes, 719.47. Now let's go ahead to the future. It now is October 1st, 2014. We now into ICD-10. So let's recode this. So we go to Chapter 13. This is a disease of musculoskeletal system, connective tissue. We go to M20, acquired deformity of fingers and toes. The first thing we see is the dash. We know that the code is not complete. We have to continue developing this particular code. Then we scroll down, we see M20.4 dash, other hammer toes acquired. Now we know at this particular point, we're still nonspecific. And also, the fact is the dash there means that this particular code still has to be developed. And we continue scrolling down, and we see M20.42. Other hammer toes acquired, left foot. Two things we notice. We now have laterality. It's on the left foot. And there's no longer any dashes, which means now the code is complete. So our ICD-10 code for hammer toes acquired, left foot is M20.42, complete code. And notice, how many characters do we have? 5. Very simple. That will be your diagnostic code for hammer toes on left foot. Okay, now let's code for pes planus, right and left feet. Again, you go to Chapter 13, and disease of the musculoskeletal system, connective tissue. And we see an M21.4 dash is flat foot, pes planus acquired. Now a question may come up and state, well, how do we know where to go in Chapter 13? We can go to the tabular index and look up flat foot and find out that the root code is M21 point, and then go to our tabular index and look up M21 point and come up with this particular scenario. Or you can go to Coding Resource Center, very simply, and go to ICD-10 and look up the code, and it will give us the root code that we will develop. So again, we get up to the code 21.4, flat foot, pes planus acquired. We see the dash, so we know the code is not fully developed. We also know there's no laterality, so we know we have to continue. Continuing onward, we see M21.41, flat foot, pes planus acquired, right foot. We have laterality. We see no more dashes. The code is fully developed. Now that's for the right foot. And as I said in the beginning, we also have the left foot pes planus. We also see that following code, M21.42, is flat foot pes planus acquired left foot. So for this particular diagnosis of pes planus, we have two ICD-10 codes. M21.41 for the right, flat foot, M21.42 for the left, flat foot. Now we go to code for pain in left toes. And again, we can use our tabular index, look up pain in toes, see that the root code is M25, and then go to our tabular, and we see, look up M25, we see a dash. This is other joint disorders. Continuing onward, we would see M25.50, pain in unspecified joints. Of course, we know we're not going to stop at unspecified. And continuing onward, we see that M25.57 is pain in ankle and foot and joints of foot. We know it's still not complete because why? We don't have the laterality. So then we continue onward and we see M25.572, pain in left ankle and joints of foot. Well, let's compare now. Our comparison chart. So we start off with IC9 code of 735.4 hammer toes. Notice at this particular point, there is no mention of any type of laterality. Not necessary. We can use this diagnosis code today with the proper CPT code and get paid. Not a problem. But now let's turn to ICD-10. Same code, same diagnosis, is now M20.42. And what we see as a difference is that we have laterality. Hammer toes acquired left foot. Let's go back to IC9 for our pes planus, our flat foot. 734.0. Acceptable code. Let's take the ICD-10 version of this. M21.41. Pes planus, our right foot. Notice I need a second code to describe the right foot. I need a second diagnostic code, ICD-10 code, to give a diagnosis of left foot. You see it's M21.42. So where in ICD-9 I was able to get away with one code for pes planus, 734.0, I need two codes in ICD-10, M21.41 for the right, and M21.42 for the left. Now we go to pain and joint. ICD-9, 719.47, pain and joint. And my equivalent ICD-10 would be M25.572, pain in left ankle and joints of foot. So let's put this all together. So if we're going to code for this particular initial encounter for a patient with painful hammer toes, the left foot, it would be very simply as follows. In our ICD-9 system, M20.42, hammer toes acquired, left foot. M21.41, pes planus of right foot. M21.42, pes planus of left foot. And M25.572, pain left ankles and joints of foot. So in reviewing this, what do we see? We see that an important point of this particular chapter is being very specific, especially when it comes to laterality. This also teaches us that in writing our notes, we have to be very, very specific in order for our codes to pick up and make certain that the right diagnostic codes are put together for the proper CPT codes and the proper documentation. Trying to get away with one unspecific diagnostic code is not going to help us. We also learned, too, that in this particular chapter, the largest code that I have really is M25.572, which is only 6 characters. So in this particular encounter, we did not have to use the 7th character or the extension code. So again, not all ICD-10 codes must be 7 characters. What we'll be doing 2 weeks from today is continuing with this. What I plan on doing is get more and more examples, since we went over the ground rules, of how to use the ICD-10 system in making diagnostic codes. At this point, I'd like to entertain any questions, and I'd like to introduce Paul Kinberg, Paul Kinberg, who's chairman of our coding committee. Paul?
Good evening, Larry, and good evening, everyone, and thank you for attending our webinar this evening. The first question we've got is, someone is asking that this is the first webinar they've been attending, and they want to know when we speak about chapters, what book are we talking about? I'll take that one, and we're actually talking about the ICD-10 book. You can get that online through the CMS website, or as Dr. Santee said at the introduction, all of this information is online at the APMA website on the Coding Resource Center. So you can certainly go to the Coding Resource Center and see all this information via chapter there. But when we talk about chapters and subchapters, all of that is ICD-10 that you can find either in the book online or through the Coding Resource Center. The next question we have is, what do you do if the problem is bilateral? Dr. Santee?
If the problem is bilateral, like we did in pes planus, you would have to give the proper diagnostic codes for both right and left. Many times in ICD-10, you'll have multiple codes for multiple areas. If that does not exist, then you must do laterality.
Thank you, Dr. Santee. There was a slight glitch, and I will apologize for the slides. We did have a question that when we were showing the pain and limb slides, we jumped from M79.60 to M79.67. And what you're seeing there is the progression in the tabular section from the M79 series codes, from the M7960 to the more specific M79.67 series code for pain. And I think Dr. Santi is scrolling backward frantically as I'm talking about that. Yeah, right there at the very bottom. It goes from M7960 pain and limb unspecified to M79.671 pain in right foot.
Oh yes, we have something missing. Correct.
Yeah, you can see with the dash, as he's said several times this evening, you need more specificity, and you have to go either to the Coding Resource Center or to your book to find that more specific code. And the most specific code for what he was defining was the M79.671 code.
You know, Paul, what's also interesting too is because of our dashes, the system allows you to keep going, and you don't stop until you don't see any more of these dashes. So actually, by progressing the way we did, you'll know when the code is complete. And the other thing too, like I described before, is we know we have to have laterality. You cannot stop building that code until you come up to the digit for laterality, which is going to be the 6th character.
Okay, another question we have is, how far will the electronic health records systems take you in doing the coding? And really, we can't speak to specific programs and specific systems. Each one is going to be different. The problem that we all are going to have is your workflow and how that workflow will happen in each individual office based upon how your own individual computer system is going to do it, whether or not it will take you through the rubric and base codes and let you build or build to the proper and final code, or whether or not the system that you have in your office will require you to know that complete code before you can input it into your system. So this is something that you really have to get to your vendor and talk to them and see how they are going to do ICD-10 in your system. The other thing that we're finding out very quickly is that we've gone from well over 1,000 electronic health record systems to probably slightly under 100 that are certified now in meaningful use stage 2, and they're dropping. So you need to make sure that your system will be able to handle ICD-10 and will be able to handle meaningful use 2. Did you want to add anything to that, Dr. Zanni?
Oh no, I agree with 110%.
Okay.
Exactly. Yeah. The other thing I'd like to just make a comment on is that I know a lot of the systems, especially when you go to various conferences and exhibit halls, they brag how all you have to do is punch in the IC9, it'll get you the complete ICD-10. Obviously, like Paul has stated, the only thing they can really give you is the root or the rubric's code itself, and that code has to continue to be developed depending on, of course, your documentation.
And if you do punch in the ICD-9 code and expect the mapping to take you to an ICD-10 code, it's going to take you to an undefined code, which we've been told, and we will repeat through every seminar, most insurance companies will not recognize and will not pay. So do be very careful if you're using the GEMS, the GEM mapping systems to take you from ICD-9 to ICD-10, that it may not take you to the complete and the appropriate code.
Right.
Next question we have, when you have pain in the joint in ICD-10, it says pain in, for example, the left ankle and foot. What if there's only pain in foot and not in the ankle, or vice versa? When you see foot and ankle, or ankle and foot, read that and/or, so it can refer to either the foot and the ankle, or just the foot or the ankle. If it's the terminus of the code, if you've taken it out all the way, and that's the last code that you see, it's going to be the ankle, the foot, and could be even toes, unless there's a separate set of codes for toes. So remember that and stands for and or, not just both of them. Next question here. If the patient's been seen for a painful hammer toe on one foot, do we have to code for the asymptomatic foot?
I'll take that, Paul. The answer is no. If that's not part of your treatment, or if that's not part of your focus of that particular exam, you just have to code for the particular part of the body that you're going to be treating. And if it's the right foot, it'll be the right foot, or left foot, vice versa. Now, in this particular case, when we examined the patient, they had pes plants both right and left foot. So that's why I coded with the laterality of right and laterality of left.
Okay. Another one for you, Dr. Santi. In your example for pain in the toes, how do you know to choose the and they're saying M25.572 versus the M79.675 in your slides 42 through 45?
Very good question. The M25 is it's actually a more specific code that will allow me to get down to the foot and toes, where the M79 code was a general code just for pain and limb. And I'll be honest with you, either or code would have been satisfactory. But since, again, tonight we're going over specificity, I decided to go with the more specific code.
Okay. And then to add to that, so do we actually, the question is, so do we actually have to state pain and joint as opposed to just stating pain?
Well, pain, again, I want to try to be as specific as possible. If we're discussing hammer toes and the pain is in the hammer toe and the toes, I will be as specific as possible in describing foot and toes rather than just generalized pain. If we're dealing with, for example, osteoarthritis or osteoporosis and there's generalized pain, then you can use the more non-specific code for pain.
Another question we have, is it necessary to code both the hammer toe and the pain codes? Won't just coding hammer toe suffice for payment?
Well, I'll take that. And again, it depends on your insurance company. Many companies do not accept the fact the patient just has a hammer toe. Why is the patient in your office? Because of pain. And I think even with the ICD-9 system, many of our diagnostic codes want the diagnosis of pain. For example, VORCA and many companies would not be covered unless it's VORCA with pain of limb. So again, you can get very, very specific and use numerous ICD-10 codes here. But again, in our particular example, we had the patient who had hammer toes, flat foot, and just generalized pain in the limb. And those are the three codes that we utilized.
Okay. The question is, it's been stated that the CMS crosswalks are incorrect. Therefore, this questioner says, I'm unsure what publisher I should trust to be correct. It's not that the CMS crosswalks are incorrect. It's that the crosswalks take you to an undefined code rather than to the proper correct finite code that you need. So when you use the crosswalk and go from ICD-9 to ICD-10, it's going to take you, as you saw in Dr. Santi's examples, not to left or right, but to the unspecified foot. You have to go to the tabular section and pick up, based upon the medical records that you've already created, whether or not you're dealing with a right foot or a left foot if laterality is involved. And there are some cases, such as plantar fasciitis, for example, that do not have laterality, so you'd be safe in just going straight to plantar fasciitis since there is no laterality involved. Another question is, go ahead, Larry.
Yeah, but I was going to say one more thing. The other thing, too, with the GEMS is sometimes you can't find your ICD-9 code as it's crossover to ICD-10. For example, if you look up bunions in general, there'll be no ICD-10 code for bunions because the GEMS only recognizes hallux adductor valgus, hallux rigidus, hallux limitus. So again, there are certain terms, such as general terms of the bunions, which will not cross over in the GEMS. Not that GEMS are incorrect, it's just incomplete.
And in that example, until we have asked for bunion to be put in the system, it may come up in 2015, but not when we go live in October this year. So you'd have to go to the alpha index. If you looked up bunion, it would direct you to hallux valgus deformity. Next question, do we have to use a pes planus, diagnosis when the patient presents with a hammer toe deformity?
The answer is absolutely not. In this particular case, what I did when I examined the patient, one of my diagnosis was a pes planus. I just gave it as an example. If the patient came in, did not have a pes planus, all he had was a hammer toe, a painful hammer toe, I would just code for hammer toe with pain.
The next question we have is it still necessary to use the LT and RT modifiers on the CPT codes? And the answer is CPT codes stand distinct and separate from ICD. So if you are required to use an LT and RT modifier, for example, with x-rays, the answer is yes, absolutely. Or with padding and strapping, or with injections, or with any number of things, you would have to use the LT and the RT modifier. But if you don't need one, for example, with an E&M code, then no, you don't have to put down LT and RT on CPT because they are separate and distinct from ICD. Now, at some point in time in the future, the insurance companies may have sophisticated edits where they're looking at your diagnosis and you're saying you've diagnosed a problem on the right foot, and they're going to want to see, for example, if you have an x-ray, that you also took the x-ray on the right foot. But right now, I can't tell you with any certainty that those code edits will be in place when they go live. The next question is there any possibility they, and I'm not sure who they are, will hold off on implementing ICD-10 in October and push it back? I would tell you that if they were going to postpone ICD-10 as they've done once so far, they would have done so already. We're just a week or so away from 6 months out, and everybody is set to go live or is preparing to go live. So if that postponement would have come, it would have come months ago, and not at this point in time. I don't think that the protestations from the AMA or any of the other organizations at this point in time will have any sway over the Secretary of Health and Human Services. I don't know if you on the board, Larry, have any additional information that you'd like to talk about.
No, I only have a dream wish that hopefully if they make any modifications, maybe they'll make modifications to the point where we don't have to go as specific as we're discussing tonight. For example, we can leave out the laterality or the seventh character. But at this stage of the game, I think the train has already left the station. And now we're looking at it coming, barreling down the track. And we have to hop on.
Yeah, well, the train's not only left the station, it's getting ready to pull into the next station. So
exactly.
That's why we're doing these webinars, and hope that everybody who's listening and will listen to these in the future will get the message and be prepared.
By the way, Paul, I'd just like to make one comment. As far as professions are concerned, we've been told numerous times that our profession, podiatry, is the most advanced profession when it comes to ICD-10s. We hear this over from many of the insurance companies. And again, we have to thank our APMA and all the work we've been doing to help put together these terrific webinars and instructions.
Here's an interesting question. The questioner says, I code only for the chief complaint plus medical conditions affecting the chief complaint. Does reimbursement depend on using all the conditions seen?
I'm going to try to answer that, Paul. You know, it's interesting that that question was asked because we had the same question when we met as a committee back in May. And when we talked to various companies, they're looking to be as specific as possible with many diagnostic codes as possible for that particular condition. And I think that's one of the reasons why most of the companies are allowing up to 12 diagnostic codes per encounter. So the answer to that question is be as specific as you can.
Okay. A question for you, Dr. Santi. It says, why did you use M25 instead of M79 for pain in right foot for your hammer toe?
I thought we answered the question before, but I'll answer it again.
I did too.
The M25 I felt was a little more specific because it brought us down to the joints of the toes, whereas M79 was more general. I think either or would suffice. I don't think that would make that much of a difference.
Okay. Another CPT-related question asks, CPT codes only allow 4 ICD diagnoses. It seems that CPT may require more than 4, so what do we do with respect to ICD-10? The answer to that question is there is a new CMS 1500 form out that is now being used concurrently with the old CMS form. Come April, I believe it's April 2nd, you will have to use the new form if you're working on paper. The change from 4010 to 5010 increased the number of allowable diagnoses from 4 to 12. Now, depending upon your vendor, some vendors will allow multiple ICD diagnostic pointers per CPT code. My particular vendor, for example, although I can now have a total of 12 ICD diagnoses, currently now 9 and soon to be ICD-10 diagnoses on the form, I can only have 4 pointers per CPT code. So that's how you're going to handle it, and you're going to have to pick and choose the right diagnostic pointers, presumably in the right sequence, depending upon how the claims edits will go. And these are some of the questions that we're still waiting to have answered in the future. Currently, Medicare, for example, does not require any specific sequencing of ICD-9 coding. ICD-10 is much more specific in respect to how they want the code sequenced, and we're waiting to hear from the various MAC carriers and from CMS how they will require that sequencing to go. So stay tuned. There's much more to come. Another question, is it necessary to always code for a musculoskeletal condition and also list a code stating the condition and the cause of pain if it exists? As in your example, you used M20.42 for acquired hammer toe of foot and M25.572 for pain in the left ankle and foot.
I'll take that, Paul. Again, it's really not necessary to use the pain code to give the diagnosis of a hammer toe. I did it only because it was part of the patient's profile. Patient came to the office with pain. Patient had a hammer toe, and patient had pes planus. So I used those particular elements in coming up with my various diagnoses. But again, every practitioner will look at a patient differently and either add more diagnostic codes or possibly even less. The key here is to be as specific as you can to give a good picture of that particular encounter and your treatment of that particular encounter.
Okay. The question is, and it's a pleasure to have someone ask this question and to answer it, is the Coding Resource Center specific to podiatry, or is it general like CMS? And I will tell you that the Health Policy and Practice Division of APMA has worked for a number of years to have the best and most specific podiatry coding resource available in the world. And you cannot find anything, I would tell you, anywhere around that is as specific as it is for podiatry and as complete as it is for podiatry. And I will toot APMA's horn far and wide to get that message out.
Well, I think we have time for more questions. Yeah.
Next question we have is, can we see an example of a code that has a placeholder? You will in the future. These lectures are coming through in a particular sequence. I know I have a lecture scheduled for, I'll tell you, August, that actually you'll see 3 placeholders in some of the examples that I'll be giving you. So when you, as a general rule or as a specific rule, when you have to complete a code, when it has a required 7th character, but the code only goes out to 3 or maybe 4 or 5 codes, you may have to use 1 or 2 or possibly even 3 placeholders to fill out that code so that that last character that Dr. Santi shows you, the A, the D, or the S in the non-fracture series, fits into that 7th spot, because all of the insurance company computers are going to be looking for it in that spot, and if they don't see it there, it will not be a recognized code. We have a question, in the case of plantar fasciitis, there's no laterality, but would you still have to code for pain and laterality associated with the pain left or right?
Well, I'll take that question.
Okay.
I think that if you're going to do a type of treatment in which requires either a surgical procedure or something that has to do with the pain that the patient is exhibiting, yes, I would go ahead and code it for pain and put the laterality.
Okay. A questioner is asking what ICD-10 manual we recommend. Again, we're not recommending an ICD-10 manual. We are recommending the APMA Coding Resource Center. All of these lectures are geared to the Coding Resource Center. The fonts, the format, and everything you see is exactly as you will see it on the Coding Resource Center. Every particular publisher and company that puts out an ICD-10 manual has a different set of how they're going to tell you that codes are required, that additional codes are required, that a seventh character is required, that you'll need to have more specificity and complete the code out. And because of that, we have a particular way of doing things with the Coding Resource Center, and that's the way we've done it. You're on your own. There are probably dozens of ICD-10 manuals out there in print. I'm sure you can go to Amazon or Google or wherever you care to go and find them. But again, we're recommending the Coding Resource Center because it has everything you need for coding podiatry claims. It has the current CPT. It has both ICD-9, ICD-10. It has HCPCS, which are the codes you'll need if you're doing durable medical and injections and medications and the like. And it also has links to all of your Medicare carriers throughout the country. So it's a one-stop shop for everything you need, and it's priced competitively and at a discount over what you'd have to spend if you're buying all the books and all the other resources. So that's why we chose to write these lectures and put them on with the fonts and the formats from our Coding Resource Center. Okay, the question here is, go ahead, Larry.
Yeah, no, I was going to say, let's make this last question. I think it's time to wrap up. So,
okay. In order to bill a 99213 visit, will they be looking for multiple codes, for example, pes planus, hamarto, and pain in limb, and will be having to add systemic diseases, i.e. diabetes?
Well, I'll take that.
Okay.
Remember now, the 99213 is a CPT code, not a diagnostic code. So in order to build a level 3 visit, you have to make certain that you do the proper documentation for a level 3 visit. And like I explained at the beginning of my examples, we made these examples focused. These are not any representation of a type of a level visit. As far as diagnostic codes are concerned, as well as your SOAP note is documented, you should be able to pull diagnostic codes out of that note and code them with the ICD-10. So it's not the number of codes, diagnostic codes we put down that determines our level of visit. It's actually the way we document that level of visit that determines the level.
Okay. I think we're just about at that witching hour, Dr. Santi.
Yeah, yes, we are. Thank you. Thank you, Paul, for helping us out in the panel. Well, that's all the time we have for questions. So thank you all for participating in today's presentation. Be sure to register for the 5th IC10 is here webinar, scheduled for March 6th at 8 p.m. IC10 webinar series 4B, which is still the disease of the musculoskeletal system, connective tissue. Like I said, it's a large chapter, so we're going to take it slow. And our next presentation will have more and more examples. So I think now we've got our ground rules down, we'll be able to go ahead and utilize them. I think as we do more and more coding, I think our members will see how easy it is to convert over to an IC10. And our presenter for the next webinar will again be me, Dr. Larry Santi. So thank you, and everyone have a good evening.